Hi guys, welcome to my channel. Today I'm going to discuss a novel drug which is anticoagulant Rivaroxaban. Its brand name is Xarleto, which is direct factor XA inhibitor. Rivaroxaban is a direct oral anticoagulant that prolongs blood clotting by preventing thrombin generation by inhibition of factor XA. So it's a direct factor XA inhibitor. FDA approved Rivaroxaban in October 2018 to reduce cardiovascular events in patients with chronic coronary artery disease or peripheral artery disease. In October 2017, 10 mg dosing is approved to reduce the continued risk of venous thromboembolism. Currently, Rivaroxaban is only funded with special authority approval for a short period of prophylaxis following total hip or total knee replacement. Indications of Rivaroxaban: prevention of stroke and systemic embolism in people with non-valvular atrial fibrillation (NVAF) and at least one risk factor, that is congestive heart failure, hypertension, age greater than and equal to 75 years, diabetes mellitus, previous stroke or transient ischemic attack, prevention of venous thromboembolism following knee or hip replacement surgery, prevention of recurrent deep vein thrombosis or pulmonary embolism, the treatment of DVT or PE. Contraindications: this drug is contraindicated if they are actively bleeding or have a high risk of major bleeding, have prosthetic heart valve, have moderate to severe hepatic dysfunction associated with coagulopathy, have renal dysfunction with creatinine clearance less than 30 ml per minute. Use Rivaroxaban with caution in patients with any disease state in which there is an increased risk of hemorrhage, because it is anticoagulant and it can increase the bleeding. The concomitant use of other drugs that affect hemostasis and NSAIDs increase the risk of the bleeding. Dose adjustments are required in patients with creatinine clearance less than 50 ml per minute. The dose of Rivaroxaban is available in 2.5 mg, 10 mg, 15 mg, 20 mg. In case of deep vein thrombosis for prophylaxis, DVTP, orthopedic surgery, indicated for prophylaxis of deep vein thrombosis, you can pronounce as DVT. We use this term in later slides, DVT. So it is deep vein thrombosis which may lead to pulmonary embolism, which we shows with PE in patients undergoing knee or hip replacement surgery. For the knee replacement, you have to give 10 mg oral each day for 12 days. Q day means each day, and the hip replacement 10 mg oral Q day for 35 days. You can take this Rivaroxaban with or without food. Administer initial dose at least 6 to 10 mg after surgery once hemostasis may be established. So in second case, non-valvular atrial fibrillation we indicate with AF, indicated to reduce the risk of stroke and systemic embolism in patients with non-valvular atrial fibrillation. 20 mg oral each day with evening meal. DVT or PE treatment, indicated for treatment of DVT and PE. 15 mg oral quantity 12 hours for 21 days with food. Then 20 mg oral each day. Reduction in risk of recurrence of DVT or PE, indicated for reduction in risk of recurrence of DVT or PE in patients at continued risk of recurrent DVT or PE after completion of initial treatment lasting less than 6 months. 10 mg oral each day with or without food after at least 6 months of standard anticoagulant treatment. Benefits of Rivaroxaban over other anticoagulants: choice of DOAC, Generally, the decision to select anticoagulant therapy depends on the case-by-case situation or consideration given to the clinical characteristics of the patient, the features of anticoagulant, the patient's preferences, the prescriber's experience, and concurrent medicines. These are the basis for the choice of DOAC. Choice between DOAC and warfarin. At beginning, the choice of anticoagulants has been between warfarin and dabigatran. As Rivaroxaban is new DOAC, the choice between DOAC and warfarin has been changed. Rivaroxaban provides many of the same advantages as dabigatran in comparison to warfarin. Its onset is rapid, dosing is standardized, take into consideration renal function. Iron testing is not required. Fewer significant interaction with other medicines and foods. Warfarin, however, is the preferred anticoagulant in patients with prosthetic heart valves. So, if the creatinine clearance less than 30 ml per minute, dabigatran Rivaroxaban, except low dose and short-term use following joint replacement surgery, are contraindicated. The long half-life of warfarin, that is 40 hours, may provide more protection against thromboembolism than a DOAC if a dose is missed. And regular INR testing may encourage adherence. Patients who are concerned about the risk of bleeding may find INR testing and the availability of reversal agent of warfarin in primary care reassuring. Bleeding rings may influence the treatment decisions. Dabigatran and Rivaroxaban are associated with less risk of intracranial hemorrhage than warfarin, but more risk of GIT bleeding. So precaution in using with PPI. So a person who is taking proton pump inhibitors, there is more chances of GIT bleeding when he takes Rivaroxaban or dabigatran. So preferred anticoagulant in that sense is warfarin. Intracranial bleeding is perhaps the most concerning adverse effect of any anticoagulant treatment, and the lower risk associated with dabigatran and Rivaroxaban may mean that DOAC is preferred to warfarin. If a patient has a high risk of GIT bleeding, the preferred anticoagulants are warfarin and reduced dose of dabigatran 110 mg twice daily. The safety and efficacy of Rivaroxaban compared to other anticoagulants. Rivaroxaban has similar rates of major bleeding as warfarin, but less intracranial bleeding. Rivaroxaban may be associated with a higher risk of bleeding than dabigatran. Rivaroxaban has not been associated with an elevated risk of myocardial infarction. In this slide, you can see a flowchart which shows switching from one anticoagulant to another anticoagulant. The one anticoagulant which is warfarin, and you can switch from warfarin to Rivaroxaban and dabigatran. Stop warfarin, measure INR daily, initiate Rivaroxaban when INR is less than or equal to 3 if taking for stroke and systemic embolism prevention, or when INR is less than or equal to 2.5 if taking for treatment or prevention of DVT and TE. So in case of dabigatran, stop warfarin, measure INR daily, initiate dabigatran when INR is less than 2. If a person is taking Rivaroxaban, then switching to warfarin, initiate warfarin while still taking Rivaroxaban, withdraw Rivaroxaban when INR is greater than or equal to 2, start warfarin at a standard dose and adjust dose based on INR after 2 days. Or in case of dabigatran, take first dose of dabigatran 24 hours after the last dose of Rivaroxaban. Or a patient taking dabigatran, switching from dabigatran to warfarin if you have to measure the creatinine clearance. If creatinine clearance greater than or equal to 50 ml per minute, start warfarin 3 days before stopping dabigatran. If creatinine clearance 30 to 49 milliliter per minute, start warfarin 2 days before stopping dabigatran. Or switching to Rivaroxaban, Take first dose of Rivaroxaban 12 hours after the last dose of dabigatran. In this slide, there is a ACCP updated guideline 2012 for the antithrombotic therapy in AF. So there is a risk category, recommended therapy, and grades. Risk category: if CHADS2 score is 0 and the low CHADS2. CHADS2 stands for C for congestive heart failure, H for hypertension, A for age, D for diabetes, S for stroke. So in that sense, there is no therapy rather than antithrombotic therapy. In patients who choose antithrombotic therapy, 75 mg to 325 mg of aspirin once daily should be given. Then combination of aspirin and clopidogrel should be given. So in case of intermediate, score 1, oral anticoagulant therapy rather than no therapy. You have to give the oral anticoagulant therapy in case of intermediate. Oral anticoagulation rather than aspirin, or combination of aspirin and clopidogrel. So at the score 1, you have to give the oral anticoagulation coagulants like Rivaroxaban and dabigatran. So in case of high CHDS2 score greater than 2, you should continue the oral anticoagulation therapy rather than no therapy, and then aspirin 75 mg to 325 mg once daily. Along with that, combination therapy with aspirin and clopidogrel, dabigatran 150 mg twice daily rather than adjusted dose BKA therapy. In this slide, you can see proposed use of anticoagulants in AF. Needs warfarin based on need CHDS2 score. Avoid dabigatran patients with CAD. If the patient has CAD, chronic artery disease, so you have to avoid the dabigatran. Now there is 2 cases. If high dose PPI, so if a patient is taking high dose PPI, so it may inhibit the absorption of dabigatran. So if INR is less than 7 out of 10 or greater than 2, there may be 2 cases if CHDS2 between 2 to 3 and CHDS2 greater than 3. In case of 2 to 3 range, you have to check the age. If age is less than 75, then you have to give the dabigatran. If age is greater than 75, then you have to give the apixaban. But in case if CHDS2 score is greater than 3, the only choice is Rivaroxaban. So Rivaroxaban should be given when the score is high. Or if in the second case, if 7 out of 10 INR or greater than 2, so in renal failure patients, warfarin may be safer, or the patient is renal failure, so warfarin safer. In that case, you have to continue with the warfarin. So it's all about Rivaroxaban. We have learned in this slide definition of Rivaroxaban, its indications, its contraindications, its dose, which is very important. And then we learned the benefits of Rivaroxaban over other anticoagulants, and the choice of oral anticoagulants, and the choice between oral anticoagulants and warfarin. Then safety and efficacy of Rivaroxaban compared to other anticoagulants. Then we learned switching from one anticoagulant to another, and then ACCP updated guidelines of antithrombotic therapy in AF. Then proposed use of anticoagulants in AF. I have taken all these content from the following references like www.bpac.org, Medscape, and www.drug.com. You can learn in detail about the Rivaroxaban if you want to learn more from these references. So I hope you like my video. Kindly like my video, subscribe my channel, and never forget to click on the bell.